Welcome to this online education presentation on neonatal hyperbilirubinemia, a clinical overview. I'm your presenter, Dr. Therese Verklen. The program is accredited for CEs and is supported by Philips Healthcare. Jaundice is the most common clinical condition that requires evaluation and treatment in neonates. Due to unconjugated bilirubin, it's usually a benign condition. Most infants can metabolize the unconjugated bilirubin so that the incidence of Kernicterus is very low. After reading or listening to the module, the participant will be able to discuss the physiology and pathophysiology of hyperbilirubinemia, identify etiologies of neonatal hyperbilirubinemia, conduct a physical evaluation of the neonate with jaundice, and evaluate treatment strategies, including phototherapy, for the neonate with hyperbilirubinemia. So what is jaundice? Jaundice, also known as Icterus, is the yellowish discoloration of the skin and sclera caused by the presence of bilirubin in elevated concentrations. Although visual determination of jaundice is not reliable, the total serum bilirubin will be approximately 6 to 7 milligrams per deciliter. Jaundice appears from the head and then progresses down towards the toes, and it regresses from the toes back up to the head. And as far as I know, the reason for the pattern is not known. Jaundice occurs in both low and high-risk term and preterm neonates. The great majority will not require any type of intervention for the jaundice. What is bilirubin? Bilirubin is thought to be an antioxidant. Oxidation occurs in the presence of free radicals, substances that are generated in the presence of excess oxygen. Oxidation can cause damage to cells, so antioxidants are necessary to help prevent oxidation. The exact benefits of bilirubin on the system have yet to be described, but it might help the infant transition from a relatively hypoxic environment in utero to this very oxygen-enriched environment outside of the uterus. Bilirubin is synthesized from the breakdown of red blood cells. 1 gram of heme produces 34 milligrams of bilirubin, so that healthy babies produce about 8 to 10 milligrams per kilo per day. Bilirubin binds reversibly to albumin. 1 gram of albumin can bind with about 8 milligrams of bilirubin. And once it's bound, it's transported to the liver as unconjugated, fat-soluble bilirubin. This form of bilirubin has an affinity for fatty tissues, such as subcutaneous tissue and brain tissue. Factors that decrease albumin-bilirubin binding include metabolic derangements like acidosis and hypoxia, hypothermia, sepsis, and free fatty acids such as intralipid. Bound bilirubin doesn't cross the blood-brain barrier and therefore it's non-toxic. But when albumin binding sites are saturated, the unconjugated bilirubin can circulate as free bilirubin and can cross the blood-brain barrier. This increases the risk of damage to the neurons in the brain, and you can see the bilirubin staining in the brain tissue on that slide. Once bilirubin is transported to the liver, it will detach from albumin and enter the hepatocyte. Glucuronidtransferase converts bilirubin and glucuronic acid into water-soluble gluconoride. Now the bilirubin is considered to be conjugated. In the blood, it's measured as direct bilirubin. Direct bilirubin is water-soluble, so it's not harmful. Urobilinogen is converted into stercobilin and excreted into the stool, giving stool its characteristic brownish color. In the small intestine, the high concentration of beta-glucuronidase in the brush borders can convert conjugated bilirubin back to the unconjugated form. The unconjugated form is easily absorbed from the small intestine into the portal circulation. In fetal life, this permits bilirubin to be transported across the placenta so that the mom can excrete it for the fetus. Quick check. And a natural yellow coloration of the skin is called jaundice. There are several variations of jaundice. Physiologic jaundice is the most prevalent or most seen, and that's because the red blood cells of neonates have a much shorter lifespan compared to adults. Preterm babies less than 28 weeks have about 30 days, 50 to 60 days for older preterm and full-term neonates, compared to the 120-day life cycle of the red blood cell in the adult. There's also breastfeeding, BreastMILK, and pathologic jaundice, and we'll discuss each of these. Non-pathologic unconjugated hyperbilirubinemia is also called physiologic jaundice. It develops in more than 60% of term and 80% of preterm neonates. And as said earlier, we see this when the serum bili concentration is greater than 6 to 7 milligrams per deciliter. There is an increase in the total serum bilirubin concentration between days 2 to 4 of life. That is phase 1 physiologic jaundice. That's followed by a rapid decline to about 3 milligrams per deciliter toward day 7 of life. The bilirubin continues to decrease until it reaches a concentration of less than 2 milligrams per deciliter by about day 14 of life, and that's the phase 2 physiologic jaundice. Physiologic unconjugated hyperbilirubinemia is considered to be pathologic when we can see jaundice in the first 24 hours of life. The total serum bilirubin level increases by more than 5 milligrams per deciliter per day. Total serum bilirubin level is greater than 12.9 in a term and greater than 15 in a preterm infant. The total serum bili level is in the 95th percentile for age in hours, or is jumping the tracks. And we'll talk about that with Butani's nomogram. And we consider this pathologic when jaundice lasts for more than 1 week in a term and more than 2 weeks in a preterm neonate. Physiologic jaundice follows a typical pattern and does not present within the first 24 hours of life. Jaundice is always evaluated before the neonate is discharged from the hospital to be sure that the normal levels of bilirubin are not increasing rapidly to place the neonate in the high-risk zone as measured by Butani's nomogram. It is well established that breastfed infants have higher bilirubin levels than bottle-fed infants. Breastfed infants are 3 times as likely to develop total serum bilirubin levels higher than 12, and 6 times as likely to develop total serum bili levels higher than 15 as bottle-fed infants. The increase in milk volume for breastfeeding infants doesn't begin until 2 to 3 days postpartum, especially in the mom who's been pregnant for the first time. 1 in 10 babies who are breastfeeding will develop jaundice. Breastfeeding jaundice is a condition of dehydration due to decreased volume and frequency of feedings and delayed passage of meconium. Jaundice occurs early here in the first 2 to 4 days of life. Clinically, we see the baby being a poor feeder. He's really sleepy, he has decreased wet diapers, and of course, he is yellow. The bilirubin levels are rising and then will decrease as mom's milk comes in and the baby rehydrates. If it's necessary, the baby can be treated with phototherapy and intravenous hydration. Breast milk jaundice occurs in about 10 to 30% of breastfed infants in weeks 2 to 6 of life. And the etiology isn't well understood here. We also may have some babies that exhibit jaundice later in that first week of life, around day 4 to day 7. It's thought that breast milk may have substances such as increased fatty acids and an increased beta-glucuronidase that inhibit normal bilirubin metabolism. Bilirubin begins to rise around day of life 4 and continues to rise, and may reach 20 milligrams per deciliter by day of life 14 and then stay elevated for 2 months. This is recognized as a prolonged physiologic jaundice. Clinically, the baby is well appearing, he's well hydrated and very active. He's breastfeeding well, but he just looks very jaundiced. The American Academy of Pediatrics does not encourage interruption of breastfeeding in healthy term infants. We plan to observe, continue breastfeeding, and start phototherapy as the typical treatment. However, some providers may want to temporarily discontinue breastfeeding. And if they do that, they want to see that the bilirubin levels decrease pretty rapidly. If the levels do not decrease by 72 hours, then breast milk jaundice is not the etiology. Etiologies for hyperbilirubinemia. There are at least 3 main mechanisms that increase bilirubin concentrations. We have an increased production because of accelerated red blood cell breakdown, decreased excretion, or increased absorption. Looking at overproduction, we could have a baby that has polycythemia, lots of red blood cells to break down, or he has hemolytic disease of the newborn, maybe an RH or an ABO incompatibility. There could be extravascular blood, a hemorrhage, such as a cephalohematoma, swallowed blood, or bruising, history of asphyxia. There is decreased hepatic function and perfusion so that the liver can't process the bilirubin properly. And the baby may have a red blood cell abnormality. There's lots of different types of hereditary hemolytic anemias that include membrane defects, hemoglobinopathies, and enzyme defects like G6PD. And you can see the baby in this slide is plethoric and he's bruised. So there's lots of risk factors for this baby to develop jaundice. Looking at overproduction, Glucose 6-phosphate dehydrogenase deficiency is one of the most common inherited red blood cell disorders. It occurs in 10 to 15% of Black infants and in infants of Mediterranean, African, and Asian descent. It's a sex-linked disease that affects males predominantly. If a female has the disorder, she will be a carrier. The problems with G6PD deficiency in the late preterm infant started that whole Kernicterus crisis that we saw in the early 2000s. There's an interaction with an intracellular abnormality, which in this case is a deficiency of a red blood cell enzyme, and an extracellular factor that results in exposure to oxidant stress. And in the case of that late preterm infant, it was dehydration. The result is hemolysis and a shortened red blood cell life. The classic picture of that is the late preterm infant who is exclusively breastfeeding and mom's milk hasn't come in yet. The baby becomes dehydrated, jaundice, and begins to show the symptoms of Kernicterus. Since we now understand the issues with the late preterm infant, the incidence of Kernicterus has decreased substantially. We can have decreased excretion. We already talked about breastfeeding, but prematurity, especially that of the late preterm infant. The late preterm infant has a lower hepatic bilirubin conjugation capacity as compared to the full term, and they are at much higher risk of developing Kernicterus. Many of these babies are breastfeeding and are cared for in low-risk nurseries or mother-baby dyads in the postpartum area, even though they're immature in their ability to handle unconjugated bilirubin. The infant of a diabetic mom has a higher incidence of hyperbilirubinemia for several reasons. First, these kids tend to be polycythemic. They have an expanded red blood cell mass that will be breaking down. They're often large babies and can have bruising at birth. And they're also commonly known as poor feeders, which can contribute to a delay in intestinal motility and enhanced enterohepatic circulation. There may be cholestatic syndromes where the liver or bile duct has issues, such as Crigler-Najjar syndrome, which has an inherited disorder of bilirubin metabolism. Increased enterohepatic circulation because of delayed feeding or intestinal obstructions, and inborn errors of metabolism, galactosemia, for example, and cystic fibrosis. The literature currently does not agree on whether delayed cord clamping increases the risk of jaundice. There have been no well-controlled studies to evaluate delayed cord clamping on bilirubin levels specifically. One of the biggest issues is the fact that researchers don't define delayed cord clamping consistently. Some have it as a delay of 30 seconds, others as 2 to 3 minutes, and others until there's no pulsation in the cord. So you'll find both. Delayed cord clamping does cause, delayed cord clamping does not cause problems with jaundice when you read the literature. And you see that's an infant of a diabetic mom on the slide. Let's evaluate the neonate with hyperbilirubinemia. And the first thing we want to know, of course, is a history. What's the family history? We need to ask about disorders that are associated with jaundice, such as G6PD, any inborn errors of metabolism, especially in the siblings, any issues with liver or bile duct, such as gallstones. If a sibling required phototherapy, that should be considered as a risk factor for this neonate, who then may also need phototherapy. You can see the baby obviously has facial and scleral jaundice. We also want to know about antepartum factors such as the development of diabetes in the mother, especially if the diabetes is insulin dependent and poorly controlled. We also want to know what happened during labor and delivery. Did the mom have any signs of sepsis? Was the delivery induced? Was it a difficult or prolonged labor where there was bruising or the development of a cephalohematoma? What were the APGAR scores? If they were less than 7 at 5 minutes, what's the degree of depression or asphyxia episode? We said that asphyxia can affect the liver and impact its ability to process bilirubin. You're also going to observe that baby for risks of a subgleal hemorrhage in addition to the bruising. And then after the birth, what's the baby's general physical condition? Is the neonate showing us signs of possible sepsis? What medications has the baby been given? Is the baby feeding well or poorly? Or maybe the baby's NPO because she's a sick neonate in the NICU. Early feedings increase gut motility and decrease reabsorption of bilirubin. We also want to know what the baby's elimination pattern is. And we've talked about delayed cord clamping. Your physical examination should be a head-to-toe examination, and depending on the cause of the jaundice, the baby can show a wide range of signs and symptoms. We said jaundice first appeared on the head and face and then progressed down. The palmar and plantar surfaces are the last to be affected. Once the total serum bilirubin is about 15, all body surfaces will show jaundice. If the baby has hemolytic disease, there may be pallor in addition to the jaundice. If the baby presents with severe hemolytic disease, there's often pancreatic islet cell hyperplasia, which means the baby's been putting out lots of insulin in utero, and so as a neonate, he's going to need to be monitored closely for the risk of hypoglycemia. Hepatosplenomegaly because of congestion and extramedullary hematopoiesis may also be present. You want to look for any enclosed hemorrhages like a seplohematoma or subgleal hemorrhage. The evidence of petechiae or purpura could be symptoms of early onset sepsis. And the presence of congenital anomalies also needs to be noted because many of those are associated with an increased incidence of hyperbilirubinemia. And you can see the baby in the slide has seplohematoma. You also want to pay attention to the diagnostic data. All jaundice neonates should have their blood type and crossed and then compared to the mother's type. A Coombs test can be done on cord blood, looking for the presence of maternal IgG antibodies against the baby's red blood cells. We're definitely doing serial measurements of total serum and direct bilirubin, and we'll also obtain a complete blood count, including hematocrit, reticulocytes, platelet count, white blood cell differential, and peripheral smear for red blood cell morphology. Acute bilirubin encephalopathy and Kernicterus are preventable forms of bilirubin-related brain injury. The injury occurs when the total serum bili levels exceed the baby's neuroprotective defenses and result in damage to the neurons. When albumin is saturated, the unbound bilirubin circulates as free bilirubin and can cross the blood-brain barrier. Unbound bilirubin affects neurons, astrocytes, microglia, resulting in apoptosis in all cell lines, decreased arborization by neurons, release of pro-inflammatory cytokines by astrocytes and microglia, and decreased myelin synthesis by oligodendrocytes. ABE, or acute bilirubin encephalopathy, is a clinical central nervous system finding caused by bilirubin toxicity to the basal ganglia and various brainstem nuclei that is seen in the first few weeks of life. Kernicterus is the chronic form of ABE in surviving infants and refers to the neurologic consequences of the deposition of unconjugated bilirubin in the brain tissue. Subsequent damage and scarring of the basal ganglia and the brainstem nuclei can occur. And the hallmark of Kernicterus is usually found at autopsy, and you see that yellow staining, that icteric staining of the basal ganglia, as you see in the picture. Okay, quick check. The most common type of jaundice is physiologic. Risk factors for ABE and Kernicterus. Typically, there's an underlying disease process. There's excessive red blood cell destruction, so we have hemolysis, an ABO or Rh incompatibility, an enzyme deficiency, genetic disorder, early and fast rise in bilirubin levels. The risk for Kernicterus increase with decreasing gestational age. Our sick babies are also much more likely to suffer sequelae than a well counterpart. Metabolic acidosis, sepsis, asphyxia, all can alter the integrity of the blood-brain barrier. The exact bilirubin concentration associated with Kernicterus in a healthy term baby is unpredictable. Infants without identified risk factors rarely have total serum bili levels above 12. The baby presents with major neurologic features involving abnormalities of level of consciousness, tone and movement, brainstem functions, especially related to feeding and crying. In the initial phase, slight lethargy, hypotonia, the baby's not moving very much, poor suck, and a high-pitched cry. The intermediate phase will show moderate lethargy, and when you disturb the baby, he's really going to be irritable. Increasing tone, backward arching of the neck, and backward arching of the back, and he'll present with fever. In the advanced phase, the baby is in a deep stupor to coma. There was pronounced backward arching of the neck and backward arching of the trunk. And because of the involvement of the central nervous system and the baby being obtunded, obviously there is no feedings. Chronic bilirubin encephalopathy, Kernicterus, is demonstrated by a tetrad consisting of extrapyramidal disturbances, where the motor movement is slow, almost looks like writhing movements in the arms and in the legs. Auditory abnormalities, where they have a high-frequency hearing loss or can be deaf. Gaze palsies, where their gaze tends to look upward. Dental dysplasias, and varying degrees of cerebral palsy. To evaluate the bilirubin levels, one test is the transcutaneous bilirubin test. It's non-invasive, measures the amount of bilirubin in the skin by directing white light into the skin and measuring the intensity of the specific wavelengths that are returned. The typical sites for measurement are the forehead or sternum. This will help the clinician to evaluate the baby's risk for hyperbilirubinemia, and along with plotting the value on the normogram in hours of age, predict his risk factors. Is he ready for discharge or not if he's a healthy baby? This also reduces the number of heel sticks needed and is a key component of universal jaundice screening in our hospitals. The TSB is obtained on all neonates that show jaundice before discharge. According to hospital protocol, if the value is placing the neonate in the high intermediate or high risk zone based on hour and age, as plotted on Butani's nomogram, the baby will automatically have the total serum bilirubin drawn. And then the treatment is going to depend on what the total serum bilirubin value was. Are we going to allow him to go home? Is he going to need to stay for further evaluation? Or do we need to start phototherapy? The total serum bilirubin is the combination of conjugated and unconjugated serum bili levels. Abnormal values are influenced by baby's gestational age and postmenstrual age, as well as the baby's general clinical condition. So the American Academy of Pediatrics recommends a risk assessment before discharge in low-risk babies. The majority of hospital protocols for babies being discharged should have their bilirubin level values, whether it's transcutaneous or total serum bilirubin, plotted on this nomogram. If the value falls in the low-risk zone, there is little risk of the baby developing significant hyperbilirubinemia. The baby's going to need further evaluation if the bili level is rising quickly, which is called jumping the tracks, or if the bili level falls in the high intermediate or high risk zones. Quick check. What is a preventable form of neonatal bilirubin-related brain injury that can be fatal if left untreated? Good. Kernicterus and acute bilirubin encephalopathy, both A and B. Quick check. Which method of assessing jaundice is the least accurate? Visual inspection. Management of physiologic jaundice, that's non-pathologic, unconjugated hyperbilirubinemia, should include assessment of the adequacy and frequency of feeding, promotion and support of breastfeeding. The lactation consultant should visit that new mother at least once within 24 hours of her giving birth. Bedside nurses should be promoting skin-to-skin care and breastfeeding within the first hour of life, that golden hour. After that, the healthy mother-baby dyad should be kept together to facilitate breastfeeding. Protocols should be developed to identify hyperbilirubinemia and to measure bilirubin levels. If the neonate is discharged before 48 hours, a follow-up visit to the pediatrician is required in the next 48 hours. If the baby is discharged before 24 hours, it's recommended that the follow-up with the baby occur within the first 24 hours after discharge. And the parents or caregivers should be provided with verbal and written information regarding hyperbilirubinemia, the need for follow-up monitoring, and how the monitoring will likely be accomplished. Phototherapy is the most effective treatment to decrease the bilirubin level in non-hemolytic hyperbilirubinemia. And it has several mechanisms of action. The first is photooxidation. That accounts for 15% of photodecomposition of bilirubin. Bilirubin is oxidized to water-soluble products excreted in the urine. Photoisomerization is the major mechanism. The bili is converted to water-soluble, structure, and configurational isomers that can be excreted by the liver without conjugation. And it's actually converted to a form called lumorubin. Increased hepatic excretion of unconjugated bilirubin and increased bowel transit time also due to phototherapy. So it increases gut motility, and some babies will develop a mild to a moderate diarrhea, which will decrease the jaundice. The effectiveness of phototherapy depends on the energy output of the phototherapy unit. There are timers on the banks of those lights that should be inspected by the biomedical department. When the lights become a certain age, they need to be replaced. The bedside nurse should measure the light intensity or irradiance using a light irradiance meter. Irradiance refers to the light intensity delivered per square centimeter of the exposed body surface area. Intensive phototherapy requires spectral irradiance more than 30. If the level is low, then the equipment has to be replaced. Hospital policy should dictate the frequency of verification of the spectral irradiance, and most protocols call for at least once a shift. The spectrum of light also influences the effectiveness. Typically, a combination of the super blue and super white lights are used. Blue and green have wavelengths that very effectively conjugate bilirubin in the skin. But we don't use them because the blue makes nurses nauseous. We used to wear sunglasses back in the old days. And with the green, you can't assess the baby's skin color. And the effectiveness is also determined by the amount of the baby's body surface area exposed to the light. Now, there is some literature that says turning the neonate is not necessary, while other research says you need to turn that baby at frequent intervals. Because phototherapy only conjugates bilirubin when the light is shining on the skin, the standard of care is to routinely reposition the baby so that the light reaches as much exposed skin as possible. There are a number of methods to effectively deliver phototherapy. Banks of fluorescent lights, as we just mentioned. If those banks are used, the light should be at least 10 centimeters from a baby that's in a bassinet. If the baby's in an incubator, the bank of light should be placed 2 centimeters above the incubator. You don't want it really resting or touching the incubator top. And the fluorescent lights need to be covered with a clear acrylic shield to protect the baby and providers from that ultraviolet light. Fiber optic blankets can also be used. The LED technology has lights that last thousands of hours. It's very inexpensive to provide, and we often use these to facilitate the use of double or triple phototherapy because we can have light shining on the anterior skin surface and the blanket can have the light on the posterior surface. If it's used by itself, and is on the baby's back below the shoulder level, the eyes do not need to be covered. Spotlights can also deliver phototherapy as a standalone therapy or be used in conjunction with the bank of lights or a fiber optic blanket, and the eyes will need to be protected from the light. Phototherapy is the most common treatment for hyperbilirubinemia, but there are still side effects. Dehydration and fluid imbalances we watch very carefully. There can be increased insensible water loss. Our baby can develop significant diarrhea. We want to keep our baby having milk-based enteral feedings. These feedings inhibit enterohepatic reabsorption of bilirubin. And our high-risk neonates, especially those requiring intensive phototherapy where we have double or triple phototherapy, they should have their electrolyte levels measured once every 12 hours at a minimum. We worry about temperature instability because of the greenhouse effect of phototherapy. The neonate in an incubator can become overheated despite the air temperature being unchanged. So it's recommended to use a skin probe to detect any changes in that baby's surface temperature. We do worry about potential retinal damage, so we keep the eyes covered during therapy. The light should be turned off and the shields removed when caregiving activities are provided and during feedings. And there may be a slight risk for potential interference with maternal-infant bonding. Unless this baby is really critically ill, the majority of infants can have the lights turned off and the eye shields removed to facilitate interaction with their parents. Other more rare side effects include bronzing of the skin, and that's due to the elevated conjugated or direct bilirubin. Some babies are very lethargic, but that could be the result of the high levels of bilirubin. Some will develop some skin rashes, maybe abdominal distension, hypocalcemia, lactose intolerance, and thrombocytopenia. The total serum bilirubin is monitored throughout phototherapy, and it needs to be evaluated within 8 to 12 hours of discontinuing phototherapy because of that rebound 1 to 2 milligrams per deciliter that we expect. That's due to the photooxidation, where the conjugated bilirubin reverts back to the unconjugated bilirubin. The lumorubin, that one is permanently changed, and that is not going to change back. Reinstating phototherapy to 8 to 12 hours typically decreases the value, and then the phototherapy can be discontinued. When intensive phototherapy has not been successful in decreasing the total serum bilirubin or at any time signs of acute bilirubin encephalopathy are found regardless of the total serum bili level, an exchange transfusion will be considered. The total serum bili is often difficult to decrease in high-risk neonates that have hemolytic conditions. With the exchange transfusion, over a 2-hour time period, the hemolyzed and antibody-coated red blood cells will be removed in small aliquots and replaced with donor blood. A preterm baby will have 3 to 5 mils per kilo used, and a full-term baby about 10 mils per kilo, so that a double volume exchange is about 160 mils per kilo, and that should reduce the total serum bili by about 50%. A single volume exchange replaces 75% of the infant's blood volume. The double volume exchange replaces about 85% of the baby's blood volume. And then a rebound total serum bili of about 60 to 70% of the bilirubin's pre-exchange transfusion level is expected. And it will depend on the baby's overall clinical condition, whether a single volume or another double volume exchange will be done. And as soon as the exchange is completed, intensive phototherapy is again instituted. The nurse should be sure that CMV negative leukocyte irradiated blood products are used. That's your basic 2-nurse check with blood. The blood should also be less than 48 hours to prevent problems with hyperkalemia that occurs with older blood. It's the responsibility of the bedside nurse and medical providers to ensure that the neonate is stabilized prior to beginning the procedure. The interventions are treated before beginning the transfusion and then monitored throughout the procedure. You're watching very closely for hypoglycemia, acid-base derangements, and hypotension. After the exchange transfusion, a total serum bili should be obtained every 4 hours. Rebound usually occurs within 1 hour after the exchange. In the management of breastfeeding jaundice, the baby's enteral intake should be increased by breastfeeding 8 to 12 times per day. It is not recommended to interrupt breastfeeding. There should be no supplementation with glucose water or water. And it does require examination by a pediatrician or a nurse practitioner if the baby is dehydrated. We want to evaluate for the risk of hyperbilirubinemia, so let's know what mom's blood type is. And we can also have direct antibody testing for incompatibility done on the neonate's blood. And then follow hospital protocols for assessment, evaluation, and follow-up of hyperbilirubinemia, including diagnostic testing for transcutaneous bili or total serum bili. Management of breast milk jaundice requires that the baby be examined by a provider to evaluate for cholestasis if the jaundice is present at or beyond 3 weeks of age. A total serum bili is obtained to evaluate both the total and direct serum bili levels. The baby's thyroid function will also be evaluated, and he should be screened for galactosemia. Alternative therapies can include binding agents like agar and activated charcoal, which bind bilirubin in the gut. That decreases the available bilirubin to be taken up by the enterohepatic circulation. Phenobarbital increases hepatic ligandin concentration, and it also induces the CYP450 enzymatic system. And metalloproforins inhibit heme oxygenase, the enzyme that's responsible for catalyzing heme to biliverdin. Most commonly used are 10-mesoporphyrin and 10-protoporphyrin. These are still considered experimental because they have not been approved by the FDA. Quick check. Treatments for hyperbilirubinemia can include, yes, all of the above: phototherapy, exchange transfusion, and pharmacological therapies. We've discussed the physiology and pathophysiology of hyperbilirubinemia and its etiologies. We've evaluated the neonate for risk factors and discussed treatment strategies, including phototherapy, for the neonate with jaundice. Thank you for joining us in this educational activity, and this concludes our presentation.